Welcome to another APSAD Insight webinar. My name's Jim Hunt. I'm one of the nurse educators here at Insight. And before we begin, I would like to acknowledge the traditional owners and custodians on the land on which we're meeting today. I'd like to pay my respects to elders past and present, and I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us out there in webinar land. So thank you and welcome. Today, we've got a bit of a special interest of mine. I've been following the growth in psychedelics over the last few years and seen the changes that are potentially going to be occurring within substance abuse or substance use, and mental health services and the potential that they hold in treatment there. And so I thought it would be a good overview to have somebody who knows this subject very well to come and present a bit on the history, a bit on what's currently happening, and potentially what might be going on in the future. So it gives me great pleasure to introduce Dr. Jonathan Brett, who's a staff specialist down at St Vincent's Hospital in Sydney in New South Wales. And it's one of the hospitals that's actually going to be involved in this sort of research. So without much further ado, I'll hand over to you, Dr. Jonathan Brett. Thank you.
Yeah, thanks for having me. And it's a real pleasure to talk on this subject for a number of reasons. But it's certainly one of the more interesting areas I've become recently involved with for a number of reasons. I think it has a very colourful past, but also a really potentially hopeful future. So I could spend a whole day talking about this probably, but I'm going to try and summarize what I think are the important things and maybe just whet your appetite, because I suspect this may be a fairly new topic for a lot of people. So yeah, just to summarize, I'm a clinical pharmacologist, toxicologist, and addiction specialist at St Vincent's, and I also am a toxicologist for New South Wales Poisons Information Centre. So where does the word psychedelic come from? So I'm not sure whether you're aware, but this was a sort of an evolution of terms. It was known, this class of sort of medicines have been known, or substances have been known by many different other names, psycholytics being one, but ultimately this term was sort of arrived at, psychedelics, and the origin is psych meaning mind, and delen meaning manifesting. So just to run through a bit of history. So in my mind, there's been really kind of three major stages, or maybe four major stages, shall we say, of psychedelic experience in the sort of medical and medical research realms. So there's prehistoric and kind of ancient historical accounts and experiences. Then there's sort of more recent history, which I'll call the sort of the rise of modern psychedelics in medicine, and then the fall from grace, and then after that a renaissance, which we're currently going through. But just to run through this, so this is really, the history itself is incredibly fascinating, and really you could spend a few hours talking about this, but there's very old ancient history reports of psychedelic use, and again this is one of the earliest reports, 5000 BC, and this is frescoes in a cave from Algeria of a shaman, we think a shaman holding mushrooms. And what just to flag, everything I'm going to really talk about in the history is you can get from this link down the bottom here. Oops, we've scrolled ahead a bit. You can get from this link down the bottom here of psychedelic times, and there's a nice timeline down there if you want to delve into the history. Moving forward, 3700 BC, there's lots of accounts from this period through to about 1000 BC in sort of Central and South America of mushrooms being used, and in some ways sort of being worshipped as, sorry, it keeps moving forward there. mushrooms being used, sorry, it seems to be have a mind of its own, this one. Mushrooms being used as part of spiritual experiences and potentially, worshipped as gods. So moving forward, this is what I'll call the rise of psychedelics in modern research. So some of you may have heard of this chap called Albert Hofmann, who in 1938 first synthesized LSD-25, and he was working for a pharmaceutical company, Sandoz Laboratories at the time, and was investigating compounds as respiratory and circulatory stimulants. And essentially, the reports go that he accidentally ingested this and had and quite a high dose. I believe it was something around 200 to 300 micrograms he ingested, which is a good sized psychedelic dose, and had this incredible psychedelic experience where he went home and he thought that he was dying, and he thought that he was in the afterlife, and they described this really unexpected psychedelic experience, which is one of the first sort of modern documented psychedelic experiences without the overlay of expectancy effects, which is based on other people's descriptions of psychedelics, what might happen. Following that, there was a sort of rise and the interest in psychedelics in research really started to increase. 1947, it was first marketed by Sandoz Laboratories under the name Disolid for treating a wide variety of mental disorders. This was kind of pre-psychotropic revolution in psychiatry, and so a lot of the rest is pre-DSM, so a lot of the research into mental health disorders was fairly uncontrolled and certainly not what we'd expect by current standards. Then in 1953 was the first kind of this was a sort of the rise of the dark side of psychedelics. The first documented sort of experiments by the CIA in an experiment, MK Ultra, which some of you may have heard of. And has anyone heard of Ted Kaczynski? May or may not have heard of him. So he was actually a chap who was quite a gifted student at Harvard in the early 50s, who was allegedly part of this MK Ultra experiment where psychology students were told to write down all of their deepest, darkest secrets and the greatest fears. Then were allegedly given LSD, and those fears were kind of used against them in a sort of interrogation technique. So Ted Kaczynski was involved in those experiments, and he later went on to become the Unabomber, killing about 3 people and injuring a lot of other people. And his profound beliefs were that technology was a bad thing, and we should go back to a sort of more natural way of living. So you can see if used in a sort of uncontrolled way as a form of interrogation, then psychedelics can certainly potentially be quite harmful. Then moving forward, Aldous Huxley, some of you may have heard of the Doors of Perception that he published, and that was following a psychedelic experience on mescaline, actually, which is from the peyote cactus, in which this is sort of one of the first popularizations in Western culture of the psychedelic experience, and a lot of people's psychedelic experiences following that were in this context of that book. Around a similar time, in terms of sort of popularization of psychedelics, so Gordon Wasson went to meet Maria Sabina in Mexico. Actually, she was a curandera who was essentially a community spiritual leader that was involved in these sacred practices that had been handed down really probably for thousands of years in these Mexican Mexican cultures. So the reason that was a significant event was because so Gordon Wasson published his experiences in Life magazine, and that was really another thing that popularized psychedelic experiences in Western culture. And then, in 1958, Albert Hofmann followed up his discovery of LSD with synthesizing psilocybin and psilocin, which is the active form of psilocybin in the laboratory. And this was, this was going to really cement his what then became this sort of legendary, almost godlike perception amongst certain populations. So then moving forward, again, Sandoz Pharmaceuticals started to produce psilocybin, so laboratory manufactured psilocybin as indocybin in 2 milligram pills, which is, a fairly low dose actually, when you think about what a psychedelic dose is, which we'll come to talk about. At a similar time, you may have some really significant modern names in psychedelic research, and potentially a little controversial as well was Timothy Leary, Ralph Metzner, and Richard Alpert, who later became known as Ramdas, who sadly actually just died, I think, this year. So they started the Harvard Psilocybin Project. They were Harvard psychology professors. And for a number of reasons, including concerns around some of the methodology they're using in their research, and some sort of proselytizing of psychedelics and so on, were actually fired from Harvard University in 1963. But for all their sort of nefariousness, they did actually sort of produce some interesting research in this area. And actually, Timothy Leary is probably the one who coined the term set and setting, which has become really quite central in terms of safety to psychedelic research. We'll talk about that in subsequent slides. But in 1963, LSD first appeared on the streets in sugar cubes, and that was probably around that time that it started to be used recreationally as well, which is really significant. So then, going through to what I would call the fall of psychedelics. So in terms of like the cultural backdrop, so this is a picture from the Golden Gate Park in San Francisco, and this was what was known as the first be-in. So be-in being being, just to existence, and this was the time at which Timothy Leary allegedly first used the phrase "turn on, tune in, drop out," and in terms of what was going on in the background here, the Vietnam War had been going on for probably about 10 years at this point, and the American public was really getting quite burned out by this war. But there was still sort of ongoing efforts to draft soldiers. And around this time as well, Nixon first started his, what became very controversial war on drugs, and saying drug abuse was public enemy number one. So you've got, on one hand, some psychedelic research going on. On the other hand, this real penetration into sort of mainstream illicit drug use, and this encouragement of young people to, go against culture and go against structure, and the government's efforts to, keep structure and trying to recruit people trying to draft people for the Vietnam War and the war on drugs caused this big clash. Ultimately, what that led to was the Controlled Substances Act, which which effectively outlawed psychedelics across America, and then subsequently other countries followed, outlawing psychedelics across the world. And again, in public culture, there was, in Life magazine, there was a real backlash against, particularly against the MK Ultra kind of experiments, and LSD being thought of as a mind control agent, and causing hallucinogen fervor and really lots of adverse effects. And so there was this real sort of tension between this counterculture and this mainstream culture of the war on drugs. So what was actually going on before these drugs are outlawed? Well, actually there was an awful lot of treatment going on anyway. So there was documented over 40,000 psychedelic associated treatments. So this is sort of use of psychedelics in a therapeutic context. And actually over 1,000 peer-reviewed papers and a number of international conferences, societies formed, lots and lots of academic work. And so just as an example of one of the first placebo-controlled experiments was the Good Friday experiment, which is in 1962 by a chap called Walter Planck. And so what he was aiming to do was to show that psychedelics can actually elicit a spiritual experience. And so what he did was he took 20 theology students and he randomized half to having to giving them psilocybin, and half to giving them niacin as a as a control agent. So niacin has subsequently been used a lot as a control in these experiments because it does create kind of a flushing effect, but without obviously the psychedelic effects. And so what they found was almost all of the 10 people given the, I think 9 out of 10 had one of the most profound, it was actually done in a church, had one of the most profound spiritual experiences of their lives that they later described. And so this really confirmed that sort of, association between psychedelic use and spiritual experience as one of the first randomized controlled trials. However, looking back on that research, there was an awful lot of research that really wouldn't, probably wouldn't be published and wouldn't get through even ethics by contemporary standards. So a lot of it was single-arm stuff, which is okay if you're looking at safety feasibility, but if you're trying to show effectiveness or efficacy, then it's fairly limited if you don't have a placebo control. Timothy Leary was famously quoted as saying, placebo is pointless in these studies because everyone knows that they're getting a psychedelic. But obviously, by current standards, that's not the best approach for clinical trials. So often the settings were uncontrolled. So, they didn't have, they weren't done in specified settings or controlled replicable research settings. And so, what we now realize is the setting is actually very, very important for the kind of experience that people have with psychedelic medicines. And also lots and lots of reports of the investigators, while they were kind of collecting data and while they were giving the drug to the participants, of also taking the drug, because at the time they thought it was very important to sort of have an experience at the same time as the participants. And a lot of the research was sadly discredited because a lot of the researchers were so invested in psychedelics to the point where they're actually evangelical about them, that it really reduced the credibility of the research that then sort of was published or came up. So that's the sort of history of psychedelics. So you can see very, very interesting stuff going from, being used as part of spiritual experiences, really, you know, dating back thousands of years BC, to more contemporary, early research that was perhaps not, you know, up to current standards, but was very prolific. There was lots going on. Then, you know, a cultural context where these drugs were then outlawed. But prior to that, a lot of research going on. So just to talk a bit about the pharmacology and the science behind these drugs, they do act, so I guess there's different classes of drugs, and they can be classified in many different ways, but one of them is the receptors on which they act. And so there's a set of drugs that act predominantly on serotonin receptors, and these ones are psilocybin, LSD, and dimethyltryptamine, so DMT, and they predominantly act on 5-HT2A receptors, but also act on a number of other serotonin receptors, and possibly act on some glutamate receptors as well. And you can see from this diagram here, and I've left a reference there, predominantly these medicines act on pyramidal cells in a layer of the cortex, cerebral cortex. But you've also got these NMDA receptor antagonists or blockers as well. And the classic drugs there are PCP, so phencyclidine and ketamine. And they are stimulatory and dissociative and sometimes hallucinogenic as well. So again, just to go through the drugs. So the sort of classic hallucinogens, and we're kind of moving away from calling them hallucinogens to calling them psychedelics, because you know, it's been found that they actually do much more than just give people hallucinations. They have quite profound neurobiological effects, which we'll talk about. But the sort of classic hallucinogens, LSD, psilocybin, classically found in mushrooms, dimethyltryptamine. So you may be aware of something called ayahuasca. So ayahuasca is actually a root that's found traditionally grown across Central America, but is actually increasingly being used in investigation and research as well. And that's actually a DMT containing compound plus something called harmaline, which is so DMT classically, if you ingest it, it's actually, a lot of it's metabolized in the gut, the intestine, by monoamine oxidase. So a lot of it doesn't actually enter the systemic circulation. But if you take it with a monoamine oxidase inhibitor in the gut, such as what's found in harmaline or ayahuasca, it gives you, it's actually a lot more of it's absorbed, and it gives you quite a profound, longer acting psychedelic experience. There's mescaline in peyote, like we talked about with Aldous Huxley's experience, ibogaine and salvinorin A, so that's found in Salvia divinorum, which is a plant. We've talked about the dissociatives, which is PCP and ketamine, and there's others. So I'm kind of classing these as, you know, part of the psychedelics, but in some ways they're probably not. So MDMA, the only reason I'm sort of mentioning that there is because it has been and is used as part of a lot of research, predominantly into sort of MDMA facilitated psychotherapy and PTSD. And I'm not really going to talk about that in this presentation, but only to mention there's a lot of studies on this at the moment at the phase 3 level and beyond, to the point where the FDA is about to, or has actually registered this for use in the US as part of psychotherapy to treat PTSD. So just to sort of run through it's a bit more of the pharmacology. So again, this is a picture of Albert Hofmann, who actually died, I think, a few years ago now. So LSD is found in liquid form, but also, you know, in illicit use in crystalline form and on blotters, which is a little bit of paper where the liquid's just put onto some absorbent paper. So it's highly potent at the serotonin receptor. and you get effects as low as 20 micrograms, but a psychedelic dose is up to about 200 micrograms. Half-life is about 3 to 4 hours, but it does have quite a long duration of effect, psychedelic effects, up to about 12 hours. So psilocybin, so it is naturally occurring in psilocybe mushrooms, psilocybe mushrooms, and there's a lot of different species, but Psilocybe cubensis is probably the commonest species that's used sort of recreationally and has been used traditionally for psychedelic experiences. So again, like I said, that's a serotonin receptor agonist. Sorry, that should be agonist, not antagonist. And its effects are detectable as low as 3 to 5 milligrams, but usually you get a psychedelic effect with about 25 milligrams, which is equivalent to about 3 to 4 grams of dried mushrooms, of the cubensis dried mushrooms. So bioavailability is about 50%. So 50% of what you ingest actually gets into the systemic circulation. And psilocybin is actually metabolized to psilocin in the once it enters your bloodstream and the liver, and it's then further metabolized by monoamine oxidase. So half-life is a bit shorter than LSD, and the duration of effect is about 8 hours. Now, that's just comparing sort of intensity of effect between psilocybin and LSD. And in terms of, and this is important because of what we want if we're giving a psychedelic dose to people as part of psychedelic psychotherapy. In practical terms, do you want to be sat with someone for 10 hours, or do you want to be sat with someone for 6 hours? And so when thinking about what's the best agent to use as part of psychedelic psychotherapy research, the pharmacokinetics are a really important, pharmacodynamics are a really important consideration. So talking about the psychedelic experience, so in some ways, this is where it gets even more interesting. So the psychedelic experience classically has been characterized by intense feelings of connection. In psychoanalytical terms, sort of ego dissolution, so loss of the sense of self, and these noetic mystical experiences. So these experiences that are indescribable in words, but are incredibly profound, and whatever your spiritual inclination, whatever your religious inclination, potentially profoundly spiritual. It may be that religiosity is an effect modifier, i.e. the more religious beliefs you have, the more kind of profound experience you have in terms of that framework, but it's certainly not limited to people with religious beliefs. So in terms of the Renaissance, so this is the kind of what I would call maybe the fourth wave. So just recently, late 90s, early 2000s, and more recently, there's been a new wave of interest in psychedelic facilitated psychotherapy within a very specific model. And I'll tell you about what that model is once we've talked about some of the research. But to the point where this is where we're at. So predominantly the research is focused on mood disorders. So in terms of where we're at with that, there's phase 3 trials of treatment-resistant depression in psychedelic, using psilocybin to treat treatment-resistant depression, cancer diagnosis-related anxiety, again using psilocybin, and obsessive-compulsive disorder phase 2 trials. So of my particular interest is addiction. So where we're at here is for alcohol use disorder, LSD, psilocybin, and ketamine have all been used as part of psychedelic psychotherapy. For alcohol, nicotine, there's some results with psilocybin, and cocaine and opioids. There's some interesting results with ibogaine, ketamine and psilocybin as well. So I'm not going to run through this, but that paper there, that reference, is quite a nice summary of the recent research regarding psychedelic psychotherapy. And again, this is such a fast-moving area that was published in 2017. All right, already that's out of date. This is a rapidly growing area, and I didn't mention on the previous slide. It's such a promising area that the FDA, have expressed a lot of interest in this, and actually giving a lot of funding and early drug registrations towards research in this area. So I'm just going to briefly run through some of the studies, the recent studies, and the first one is a meta-analysis of old studies of PP, psychedelic facilitated psychotherapy in addiction, and most of this is just using LSD and psilocybin. So starting with alcohol, what we now call alcohol use disorder. So this was a study, a meta-analysis published, I believe in 2012, of studies looking at a meta-analysis of studies using LSD to treat alcoholism. And the power of this was, I guess, the size of it was over 500 people. And, you know, about 60% were in the active treatment arm, 38% were in controls, massive heterogeneity in trials here. And again, because the trials are actually dating back to some of them to the 70s, early 70s, again, there was that sort of lack of control. So lots of heterogeneity in this meta-analysis. But, you know, what they did found was quite promising results in terms of, you know, initial results, but also sustained changes at 6 months. And this is really important, which we'll come on to talk about. Another study looking at psilocybin, more recent study looking at psilocybin as a proof of concept study, but only using 10 people. And again, you'll see this is sort of representative of a lot of the trials at the moment. Because we're really just looking at safety and feasibility, a lot of the recent studies have just been using quite small numbers. And so you can see, even though some of them might show promising results, there's a lot of scope to actually then now go on and use to look at bigger studies and randomized controlled trials. But this study by Bogenschutz in the US of 10 people looked at like percentage drinking days and percentage heavy drinking days, and it didn't have a control arm, so only 10 people, but you can see there that there was a drop in both of those outcomes that were sustained, again, up to about 24 weeks, which was the duration of the study. This was another study, which is a bit older, of LSD and looking at opioid dependence of people in residential rehabilitation setting. And this was randomized controlled. And again, you can see there up to 12 months sustained improvements in abstinence following release from rehab. And the bottom study there is one of the early studies looking at actually nicotine dependence, and showing very promising results. And again, just very small numbers, 15 people and no control arm. But you know, at 6 months, 15 out of the 12 were still not smoking. At 12 months, 10, and at 16 months, 9. And so, you know, if this were actually, you know, if this did translate to the randomized control environment, then, you know, they're essentially comparable, if not much better than any interventions we have currently for smoking. What's going on at the moment in Australia? There's some really interesting studies and promising, but I'm hoping that these are going to be the start of hopefully more. So predominantly the work's going on in the St. Vincent's network. So St. Vincent, and the reason for that is because St. Vincent's Melbourne started it, and St. Vincent's Sydney have really capitalised on all the hard work that St. Vincent's Melbourne have done. And because these were some of the first studies, the first modern studies in Australia, it does take quite a lot of work to get started. But actually, once you've got things, once there's a precedence for it, then it gets a bit easier. So St. Vincent's Melbourne have got, are actively recruiting for a cancer-related anxiety study using psilocybin. And I can talk a bit more about that if people are interested. And they're just about to start a study for treatment-resistant depression. Unfortunately, a lot of the research is now on hold in Melbourne because of the coronavirus outbreaks. So hopefully at some point in the future that'll be restarted. But there's also, so I'm the principal investigator on a study we've just had ethics approval for to look at psilocybin facilitated psychotherapy for methamphetamine use disorder. Now, just to set the scene, there's also a study that's just finished recruiting in the US and Alabama that looked at cocaine use disorder, psilocybin psychotherapy for cocaine, with pretty promising results, which are unpublished as yet. So what's the rationale for these studies? Well, you know, in my mind, particularly, so my interest particularly is in methamphetamine use disorder, because we have the stimulant treatment program here at St. Vincent's. And in my mind, so methamphetamine use disorder is really one of those things where, you know, we're really struggling for effective treatments, and, you know, the mainstay of treatment at the moment remains psychological based therapies, but the effect size is modest at best. And really there's no promising, there was a recent meta-analysis showing really there's no promising pharmacological agents to treat this as yet. So it's really a condition we're really looking for treatments for. And, you know, this kind of modality was interesting to me because it was a real hybrid between psychotherapy and you know, pharmacological approaches. So I guess one of the other appealing aspects of this is there seems to be rapid and sustainable treatment responses after a single dose, or some studies maybe use 2 doses alongside a very short course of psychotherapy, compared to, you know, the other modalities that we do use, particularly, you know, in the context of methamphetamine dependence, which are, you know, potentially much more prolonged. Even for CBT-based therapies, they're over, you know, maybe 12 or even longer number of weeks. The side effects in a very controlled setting, in a very well-selected patient group, are manageable and minor. I'll talk about the safety aspects in a moment. And potentially there's a reduced need for ongoing psychotropic therapy. And, you know, particularly the group of people with substance use disorders and with things like treatment-resistant depression and other treatment-resistant mental health disorders, of which we know, you know, we've got psychotropics, but you know, the rates of treatment resistance are actually really high, anywhere between 50 and 25 and 50%, which is really not great. So hopefully we may reduce the need for ongoing psychotropic therapy. So this is where it gets, you know, where the story deepens and, you know, it becomes really fascinating. So what are the potential mechanisms of why psychedelic psychotherapy works? So particularly applied to addiction and possibly applied to depression. Well, some of the features that happen that possibly are some of the determinants of addiction, but also definitely some of the consequences of addiction are social disconnection. And so, there's that famous saying of addiction is a disorder of connection. That certainly happens. And there's a lot of good evidence that people living with addictions have impairments in mental flexibility as well, and that's the ability to think in shades of grey, not think in a binary way, but also something I didn't mention here, an ability to mentalize, so an ability to put yourself in other people's shoes. So the psychedelic experiences, the core of it, as we've discussed, is experiences of connectedness with not just with other people, but often with the universe and with nature, depending on what your framework is. And also there's good experiments showing increases in psychological flexibility, so the ability to hold lots of conflicting concepts in your mind at once after a psychedelic experience. There are also strong expectancy effects. And so expectancy effects we sort of touched on. What these are essentially what you expect to happen will happen. And so essentially, another word for that is, the power of suggestion. So how the preparation psychotherapy before the psychedelic experiment is done can set up some expectancy effects that may actually help with recovery. So there's some other really interesting theories of consciousness, which tie into the theories of consciousness as to why psychedelics might actually help in people's recovery from mental health problems and from addictions. And so the two at the heart of these theories are the entropic brain theory and the free energy principle. So just to touch on these, because they're actually quite complex. So the entropic brain theory is basically that entropy is basically describing how energy or how particles or how energy becomes more spaced apart and dissipates over time. And so what that means in neurobiology is that the brain actively needs to exert an effect in order to contain energy. And so the brain exists between states of high energy or high chaos or high connection, and low energy, so low chaos, which is very well connected areas of the brain. And so different states show different forms of criticality. Criticality is your ability to essentially, in psychological terms, the ability to rapidly change your perspective or change your way of thinking on something. So and that ties into the free energy principle, which is again describing the brain as a landscape. So as I've tried to sort of illustrate here, so the landscape represents the peaks and troughs, and particularly the troughs represent how deeply held your ideas are about yourself and the world. And so one of the principles is, if you have very deeply held beliefs, potentially negative beliefs about yourself or the world, you can get stuck in those beliefs. And so one of the theories of what psilocybin or what psychotropics do are for a period of time, they flatten this landscape. So they allow you to move, move out of one of these troughs, shift from a deeply held belief and move to sort of possibly a more productive or a deeper story about yourself, a richer story. And so some of these principles are reinforced by some recent findings in neurobiology. And some of you may be aware of something called the default mode network. So historically, we thought that, it's been well known that the limbic circuit, so mesocortical pathways are the thing that's very important in addiction. But recently it's been found that the default mode network is actually also incredibly important in terms of, what some of the brain networks that become dysregulated in addiction. And so Nora Volkoff, you may have heard of, is very well known for investigating brain networks in addiction. And so this isn't to say that, I don't believe that addiction is a brain disorder by itself, but I think that, when you're thinking about some of the modalities that can help treat addiction, it's good to help with reinforcing what causality is. So are we actually making a difference because of these brain network changes? So it's really, I think, looking at brain networks and changes are really important in this area. So what the default mode network is it's something that was discovered by functional magnetic resonance imaging, so using MRIs to look at brain flow and function in the brain in around the late 90s. And what they found was this was the network that was active when you weren't doing anything. So you weren't doing any particular tasks. And so essentially what it's, what the front part is responsible for, which is, your medial prefrontal cortex, your anterior cingulate, is attribution of personal value, emotional regulation. And in addiction, that tends to be decreased. And the posterior default mode network, which is your posterior cingulate cortex predominantly, which is something that directs, your attention inside and to the internal world, and is responsible for a rumination, is increased, and you get so essentially you get this on a very basic level. In addiction, you get this increase in rumination, self-referential thoughts, emotional dysregulation, and difficulties mentalizing. And so what's been found more recently is with LSD and psilocybin, actually some of this dysregulation that happens with the default mode network is actually remediated. So there's an increase after use of these, after administration of these medicines, there's an increase in the anterior and decrease in posterior DMN. There's a decrease in the positive coupling between these two areas, which is also another important aspect of dysregulation and addiction. And there's actually, importantly, an increased connectivity to other brain areas. So this may be something that facilitates increased mental flexibility. Okay, so that was something around the rationale. So there's certainly, if it works, there's potentially reasons why it's maybe going to be useful in mental health and addiction, and may even be cost effective for those other reasons. There's lots of theories about why it might work, and there's some really interesting neurobiology that reinforces some of those theories. But what does it actually look like? What does the contemporary model look like in terms of what's been researched? And so I mentioned before the importance of setting. And so what this means is that set means mindset, which is talking about the importance of someone's headspace when they actually are going in to have the psychedelic administered, and setting is the environment in which it's administered. So the other really important considerations in studies and in any therapy that uses psychedelics is the study personnel and the training of the therapists and how the therapy is actually done. So if you're going to embark on any research in psychedelic psychotherapy, it's really important to make sure not just your psychotherapists are trained, but all of your study personnel are aware of. Anyone who comes into contact with a patient are well trained and know what's going on. And the reason for this is, again, expectancy effects. And the influence of any contact with a patient, any therapeutic contact with a patient on their mindset leading up to the administration of the psychedelic. So traditionally, even in contemporary research, the therapy's been delivered as a dyad. And so what that means is two therapists are actually present during probably both the preparation, but definitely the administration day, and then possibly the integration sessions following administration. And the reason for that is there's some practical reasons. So the dosing day, when we're talking about psilocybin anyway, you actually get the person in to a place for 8 hours, and if you're the therapists, you sit with them for 8 hours during their experience. And so obviously if the person needs to go to the bathroom, or they're having a particularly challenging time, then it's useful to have two people around. Also, two people can't, one person can't be there for the whole 8 hours, and so it's useful to be able to take breaks. So as I said, the setting is very, very important as well. So some of the original research on this was actually done in a very clinical setting. So we didn't realize the importance. In fact, some of it was done by in people in withdrawal from substances by tying them to the bed and giving them psychedelics. And so as you can imagine, people had quite horrendous experiences. And again, this is sort of related to the effect that the environment around you forms very much a part of your psychedelic experience. And so what we've realized now is that when we're doing this, even in research, you want to set up an environment that's as least clinical and as most loungy as possible. So you can see this is a bit of an old picture now, but setting up a sofa and a very sort of lounge-like experience with ornaments and nice lighting. And traditionally the person lies down and has an eye mask, and essentially during that's during dosing day. What we think of now is it's really important to have some preparatory psychotherapy. So this can be anywhere between traditionally it's been about 5, but even some studies as little as 2 sessions. But in those sessions, the main thing is building trust and therapeutic alliance, intention setting. So really trying to clarify what the person wants to get out of the experience. And part of that is, motivational enhancement as well, particularly in the substance use setting, and psychoeducation. So a real focus on, what's going to happen during dosing day and what it might look like for you, and a lot of setting up of the safety aspects. What do you do if things get challenging? What support would you like from us if things get challenging? That kind of thing. So dosing day, in terms of the psychotherapy, really it's very hands-off approach. You're not doing any much talking at all, apart from really being there for the person and containing them and holding them during that experience. There's traditionally very little talking going on. Then, after the experience, there's integration psychotherapy, and really that's, in the weeks of the days to weeks after that experience. And, traditionally is, only 2 to 3 sessions before patients are integrated back into sort of the usual therapy. And that's really helping them make sense of the experience. So psychedelics experience can be quite disjointed in its narrative. And so it's helping people put a narrative to that experience in the context of their intentions and helping them plan for the next steps. So safety is very, very important. So given this is this area of research is going through a renaissance, it's really important that we don't have a repeat of what happened in the 60s, 70s in terms of the research area losing credibility. So there's actually there's a paper published by Roland Griffiths, who's very well-known researcher in this area, that I've put up there in the top corner, thinking about what are the important aspects of safety in these trials. But just to reinforce, like in the controlled studies that have been done so far, there's very low physical toxicity. And in fact, there's been some really great studies done on the addiction abuse potential, again, very low. And in terms of the psychological toxicities, again, it can be psychologically challenging, but all of the studies that have been done, of all the studies that have been done recently, there's only, of hundreds of guided psychedelic experiences, there's only been 1 or 2 documented cases of even people having to have like rescue psychotropics like benzodiazepines. There's certainly been no experience of people developing persisting psychosis or any issues like that. So again, like it's really important to very carefully select your patients though. So, you really want to exclude people at risk of psychosis, people with unstable or medical concerns, and people on medicines that may interact. It wouldn't be fair to do a talk like this without mentioning this thing in the DSM-5 called persisting hallucinogen perception disorder. This has only been described in people, in recent years, since the 70s, in people using recreational psychedelics. It hasn't been described in any recent trials, which is reassuring. But again, it's sort of, in my mind, a kind of a PTSD-like experience from a very bad psychedelic experience, or a bad trip. And again, it's very, very rare. We're talking less than, I think the figures were less than 500, 1 in 500,000 psychedelic experience is. So it's very rare. But we don't know the exact figures because obviously it's very difficult to measure. So in terms of other, I'm not going to talk about microdosing, but there's a paper for you if you're interested. There's also a really good organization called MAPS, which have a lot of resources and podcasts and interesting sort of papers to read. And they are, I'd say they're quite, what's the word, credible. They're not evangelical. They have a lot of resources there. Another interesting sort of popular culture resource you might want to read, which I forgot to put up here, is Michael Palin's book, How Drugs Can Change Your Mind. And this was a really, actually another sort of really important step in popularizing, the psychedelic history and psychedelic renaissance. And for anyone who's interested in this area, I'd really recommend you read that book, because it's a very nice read, and it gives you an overview of the history and research, not so much the research, but more the history and context of psychedelics. So I think that is the end of my presentation. So thank you very much for listening, and I'm sorry, I've got about, if you want any questions, I've got about 5 or 10 minutes, but then I do have to head back to my clinic, unfortunately. But anyway, thanks for listening. Some more resources there.
Thank you very much, Jonathan. Let me just open up my video and microphone. There we go. Hopefully you can hear me okay. Thank you for an excellent presentation, and a very thorough presentation, exactly what I was hoping it would be. So I'm very grateful for sparing the time for that. As I expected, we have a lot of questions and a few comments. First of all, I'd like to acknowledge Stephen Bright, who wrote in, who you may well know of, who's liked your reinforcement of the use of the term psychedelics as opposed to hallucinogens, not only because of the mechanisms of action, but also because of the stigma associated with the term hallucinogens. Somebody's written in and asked, what is the risk profile associated with psychedelics, which I know you covered a little bit, but they particularly asked, is there any evidence around research and the adolescent developing brain and use of psychedelics?
So not as far as I'm aware of, because so the in terms of like the Renaissance research, I think we've been trying to be very, certainly in Australia, probably worldwide, I think we've been trying to be very careful about safety. And so because this is fairly early days, we've been trying to be very mindful about the risk of psychosis. And so that's the thing that's on everyone's mind. And so, you know, clearly in researching methamphetamine use disorder, we've had to be quite exclusive in our study design to exclude people with risk of psychosis. And of course, one of the historical concerns of psychosis is that people who are less than 25 are, you know, in terms of the epidemiology, the highest risk of first psychotic disorder. And so a lot of the traditional studies have really even excluded those people. And so I imagine as this area evolves, we will look at studies, we will be looking at studies in that younger age group in terms of safety. But as yet, those studies haven't been done. So
I think, as you say, people are treading cautiously at the moment.
Very cautiously, yeah. I think we have to tread carefully for not just for patient safety reasons, but also for cultural and political reasons as well. Yeah.
You mentioned obviously about psychosis and the research that's going on, or that's hopefully going to carry out down in St Vincent's. Somebody's mentioned about what your screening process is for access into the research there, and whether that screening process also includes substance use disorders which may potentially have a higher risk of psychosis associated with them, such as people that might use cannabis or methamphetamine.
Yeah, absolutely. So just to say that there's actually a lot of our understanding of psychosis is really evolving. And actually, and I'm not a psychiatrist, I'll just say that up front, but my understanding is that psychosis probably is quite a heterogeneous disorder. Like many mental health disorders, there's probably many different flavors and many different neurobiological things that are actually happening underneath that. So the effects, the psychedelic effects that you get with psychedelics, in some ways are quite distinctly different to the psychosis you get with primary psychotic disorders like schizophrenia and bipolar disorder for a number of reasons. And so actually, you know, the drug-induced psychosis you get with things like, you know, methamphetamine in particular, and other stimulants, and marijuana and cannabis, you know, they're quite complex as well, and you know there's an interaction with predisposition to psychosis there, but maybe quite different to the effects you get with psychedelics. And so there's a lot of researchers that are actually arguing now that it probably doesn't matter even if you recruit people with a past history of drug-induced psychosis, but we are actually excluding those people. So, you know, in terms of Roland Griffith's criteria, we're excluding people with personal history of primary psychotic disorder, with any first or secondary relatives with those disorders, people less than 25, people with a risk of people with past drug-induced psychosis, and people, according to Monica Barrett's research, was it Monica Barrett? No, I'm trying to remember. No, Kate. Anyway, according to risk factors for you know, research looking into risk factors for methamphetamine-induced psychosis, we've tried to exclude those as well. So, you know, in terms of like duration of use and severity of dependence and coexisting alcohol and cannabis use disorder. Yeah.
Yeah. Somebody else, thank you. Somebody else has asked, what's the addiction liability or the dependence liability associated with psychedelics?
I'm glad you asked that. So there's been quite a lot of research in this actually, and several papers published to show that it's very low, if non-existent. Yes,
that's my understanding as well. It's one of the few substances that in animal models they don't go back and use again and again.
That's right. In fact, there's some really good naturalistic studies as well of people who use other drugs that use psilocybin that actually then reduce the use of other drugs, and that's some reinforcing stuff that says that it might be useful in substance use disorder. Yeah.
Yeah. Now, I'm aware that you're going to have to rush off, so please tell me if you need to cut this short. Somebody else has asked, who obviously has more intelligence than I have, that apparently a submission has been made to the TGA to reschedule psilocybin and MDMA from a Schedule 9 to a Schedule 8, which basically means it's moving it from a research chemical into the medicinal field. And they've asked, what are your thoughts around that?
Well, it certainly would make it more easy to research. I like, my gut feeling is that I think we're a ways off that being approved.
Yeah.
Just because, research is still possible with it being an S9 drug. The process for that is you need ethics approval, and then you get S9 approval from your statewide Ministry of Health. So I suspect I'd really like to see it happen, but moving it to Schedule 8 means that it is prescribable by anyone. Yeah. And so I suspect that I really hope that we develop enough evidence to say that that's going to be possible, but I can't see it happening
probably a bit early.
Yeah, probably a bit early. Maybe in the next 5 or 10 years, yeah.
Yeah, like you, I wish it wasn't, but yes, I think it is. And that kind of answers the other question that I've had. Somebody asked, if an addiction service wanted to do research in this area, what's the process? How long would it take? And I think the reality is that it's just probably not possible for an addiction service at the moment to be carrying out research in this, just because of the restrictions around the medicine or around the substances. But I'll let you answer.
I would say that it may be possible, and if anyone is interested, then please feel free to get in touch. I will say that it's incredibly difficult.
Yeah.
So the reason it's difficult is because we were really lucky for a number of reasons. One, St Vincent's Melbourne had already started doing it, and so within the hospital network there's already that precedent. Two, we had a kind of perfect storm of people that were interested. So we had the head of psychiatry who was interested, the head of drug and alcohol. I'm a clinical pharmacologist and a toxicologist, and we had very experienced clinical trials people interested. And this is just to do a pilot study of 15 people, bear in mind. And we've had to jump through so many hoops. But we've got there, right? We've got ethics approval at least, and unless you've got a lot of research capacity and background, and a lot of support, it's actually really hard to get anything across the line. So if you've got a really well-established research unit in your addiction center, then I'd say give it a shot. But feel free to get in touch if you want some advice. There's lots and lots of hurdles to jump through, but I'm hoping that as we gather evidence and there's more precedence for it, it is done more, but we have to be very, very careful how we do research in this area to make sure that it's not discredited before it gains traction. Yeah.
Thank you. I've got two other, hopefully relatively quick ones. One is treatment effective if people have already got a history of recreational use of these substances?
Well, actually, interesting question. Some of the studies only recruit people who've used it before, and to make sure, to ensure safety. And again, yes, showed very promising effects, because the principle is, you may get some benefits if you do it in an uncontrolled recreational setting, but actually the predominant benefits you get is from doing it in a psychotherapeutic setting, where you do all that preparation work and then you have the integration sessions as well. So it's much best. Maybe it is helpful if you hadn't experienced before, but it's best to do it in a therapeutic setting. There may be an element of there may be an element of sort of tolerance to the effects, but it's not great. And people continue to have psychedelic experiences even after multiple doses. Yeah.
And finally, I'll end on this one. Is there any research around the actual mechanisms of what's going on with the integration process after the experience?
There's lots of research there's lots of psychological based research looking at mediators of effect in terms of surveys and looking at correlations. And there's also some interesting research looking at neuroimaging. So whether it's like changes in the default mode network is sustained over time. Yeah, the short answer is yes. There's research looking at what are the mediators, and whether how integration is done is one of the mediators of long-term effects. So that is happening. Yeah, cool. A lot of the frameworks have either been for addiction, in acceptance and commitment framework or a motivation interviewing framework.